Good afternoon, everyone. Today I will be presenting a infected, uh, infected but indispensable case of TWAD to remove or not to remove. Good afternoon, everyone. Today I will be presenting a case of TWAD infected but indispensable to should we remove it or not. Um, my patient is a 25-year-old. Next slide, please. My patient is a 25-year-old female. She's a known case of carcinoma right breast and on treatment since 2022. And in 2025, she is diagnosed as a case of CA left breast. She's planned for chemotherapy. She underwent TVAD implantation in February 2025. Then, after a week, she presented with a local edema with purulent discharge over the TVAD site, and she was having a low-grade fever associated with that. And this was the clinical state of the patient. Next slide. Then, what should be our next step for this patient? Then we went for the blood culture. The blood culture came out positive as Staphylococcus epidermidis. The clinical dilemma with was that should we remove the port or should we salvage it or should we remove it? The port infections can be local or systemic. Next slide, please. The local infections present with erythema, tenderness, and purulent discharge at the catheter insertion site. And systemic infections present with positive blood cultures, fever, chills, and hemodynamic changes like instability in blood pressure or heart rates. For, next slide, please. The infection can be tunnel exit site infection or catheter-related bloodstream infection. The tunnel site or exit site infection is inflammation or infection along the catheter external path or exit site. And CRBSI, the catheter-related bloodstream infection, are the infection originating from the catheter. Like for the diagnosis of these patients, we usually do ultrasound or CT scan, which are useful in detecting the abscess or thrombosis near or at the catheter site. Now, the biggest thing is when should we salvage the catheter and when should we remove the catheter? The decision making for these are we should salvage the catheter when the patient's hemodynamic is stable. There is no sign of tunnel or exit site infection, and the infections are caused by low virulence organism like Coagulus secretus staphylococcus. And we should remove the catheter when there's persistent bacteremia, like ongoing bloodstream infection, presence of a port pocket abscess, infection with high virulent organism like Staphylococcus aureus or any fungi infection. Now, what is the role of antibiotics and lock therapy in these patients? This treatment of systemic, the last therapy, the systemic antibiotics. The systemic antibiotics are administered on the base of culture sensitivity result. Then antibiotic lock therapy, that is the ALT. This is the installation of high concentration of antibiotic in the port. The dwell time for these antibiotics is 12 to 24 hours, and these are used in combination with systemic therapy for to salvage the ports. If we have removed the port, when it is safe to reinsert these ports. Next slide, please. The first thing is port infection management, microbiological resolution of the infection. That is typically 48 to 72 hours a period with no fever. We should ensure that the patient has negative blood cultures before reinsertion. Reinsertion consideration should same site reinsertion. Avoid if the previous site had. We should avoid same site reinsertion if the patient has previous site had tunnel infection or abscess. Contralateral site reinsertion is preferred if the catheter was removed due to infection. Timing, it is balance between urgent chemotherapy needs and the infection control. We had salvaged the patient's catheter and we have given her the antibiotics, systemic antibiotics, and this was the after 1 week period. This was a catheter clinical picture of the catheter. Next slide. The take-home message from for the infection is we should distinguish between the local and systemic infection. Early identification is crucial for appropriate management, and we can salvage the port. Salvage if a feasibility with low virulent organism and the patient is hemodynamically stable. We should administer antibiotic lock therapy. It can avoid catheter removal when used appropriately, and safe in research requires careful timing and site selection for optimal outcomes. Thank you, everyone.